Hello, everyone. Thank you so much for joining us today. We're going to be getting started momentarily. But as folks get logged in and ready to roll here, I do have a few announcements. Some upcoming webinars on Wednesday, October 16th. We're going to have Control of Localized Fatigue with Dr. Thomas J. Armstrong in the University of Michigan Center for Occupational Health and Safety Engineering. On Wednesday, October 23rd, we'll have a presentation in partnership with the California Labor Lab on designing workplaces for neurodiverse workers. That will also be with Sally Augustin, PhD and MBA. And our next industrial hygiene themed webinar will be on Tuesday, November 12th. That will be on optimizing calibration methods for low-cost PM 2.5 sensors in high concentration occupational environments. For more about these upcoming webinars and other events, you can visit us online at coeh@berkeley.edu/webinars. And I'll go ahead and pop that link in the chat. And on behalf of the education and research centers throughout the country, it is my pleasure to present our industrial hygiene webinar series. This is a collaborative effort on behalf of each ERC's continuing education program and aspires to provide you access to current research supported through NIOSH ERC programs. We appreciate you joining us for today's session. Today's webinar, Evaluating the Impact of Implementing New PELs for the Workplace Chemicals That Reflect Cancer Risk, is presented by Jisoo, MPH, in partnership with the Northern California ERC. A few housekeeping items first. You'll be muted during this presentation. If you'd like to ask a question, please enter it into the online Q&A box. And we'll save time at the end of the presentation to address as many questions as possible. We'll also have the chat open, so feel free to use it to participate and to join in on the conversation. This presentation is being recorded and will be made available on the Center for Occupational and Environmental Health YouTube page within 5 business days. And all participants who log in with their registration email for the full live presentation today will receive an email tomorrow with a link to an evaluation form that will qualify you for a certificate of completion with 1 continuing education contact hour. Once you've submitted the evaluation, you'll be able to access and print your certificate. And without further ado, it is my absolute pleasure to welcome our presenter for today, Jisoo, MPH. Jisoo is originally from South Korea and has been studying abroad in the US since high school. She graduated from UCLA with a degree in Earth and Environmental Sciences and later pursued her studies at the University of California, Berkeley, focusing on chemical exposure. She majored in Environmental Health Sciences and Industrial Hygiene and received her Master's of Public Health in May 2024. During her time at Berkeley, she interned for a year at Tesla with the Chemical Regulatory and Risk team, where she conducted field sampling and worked on regulatory compliance. For her thesis, she collaborated with OSHA on reestablishing Permissible Exposure Limits, or PELs, to reflect cancer risk. And we're so happy to say that she's currently pursuing a PhD in Occupational Hygiene at the University of Minnesota, with a research focus on pesticide exposure assessment among pest control workers in Korea. Thank you so much for being here today and sharing your research with us. We're so looking forward to it.
Yeah, of course. Thank you so much, Michelle, for introducing me. Hi everyone. As Michelle mentioned, my name is Jisoo. I'm a first-year PhD student at the University of Minnesota, majoring in occupational hygiene. The research I will be presenting today is the thesis I wrote at UC Berkeley for my MPH degree. The title is Evaluating the Impact of Implementing New PELs for Workplace Chemicals Reflecting Cancer Risk. This research was originally outlined by Dr. Mike Wilson at OSHA, and he provided significant guidance throughout the research process. Here is the content I will be discussing today. Starting with the introduction, I will cover the background, types of OELs, variations in international OELs, the case for PELs that reflect cancer risk, and my research objectives. Next, I will explain the methodology detailing how I calculated the new PELs and assessed the cancer risk of current PELs. Following that, I will present the results, which include the comparison of new and existing PELs, as well as the quantified cancer risk associated with the current PELs. In the discussion, I will highlight important findings and address the limitations of the study. Finally, I will conclude this presentation by summarizing the research. So how I got into the topic of occupational exposure to carcinogens is that in 2020, the statistics show that 350,000 cancer-related deaths were recorded due to occupational exposures. And NIOSH, which is the National Institute of Occupational Safety and Health, has emphasized the need to minimize worker exposure to carcinogens because no level of exposure is deemed safe. But current OSHA's occupational exposure limits, which are also called permissible exposure limits, often fall short in protecting workers from cancer risk. In the US, there are four main types of OELs for various chemicals. First one is OSHA PELs, established in 1970. These are federal legal standards that companies are required to meet. However, OSHA PELs are outdated, and OSHA has acknowledged that even if PELs are followed, workers may still face unacceptable risks. And here we have NIOSH RELs, which is recommended exposure limits. NIOSH RELs are often stricter than OSHA PELs, but they are recommendations, not legal standards. These exposure limits accessible through the NIOSH Pocket Guide are regularly updated. Third one is the ACGIH TLVs, stands for threshold limit values. It is developed by the American Conference of Governmental Industrial Hygienists. TLVs are typically more stringent than OSHA PELs, but like NIOSH RELs, they are recommendations, not enforceable legal standards. TLVs are updated twice a year. Here we have OSHA PELs. So California OSHA has its own set of PELs, which are stricter than federal OSHA PELs. Unlike the other OELs mentioned, OSHA PELs are legal standards within California and are usually updated every 3 years. Looking at how its exposure limits are being established, except for OSHA PELs, other exposure limits, they are in a hybrid format, which means that they consider both technical enforcement and health-based factors. However, none of them consider carcinogenicity as a health endpoint. There is a clear challenge in addressing the cancer risk posed by occupational carcinogens with the current exposure limits. In response to the growing risk of occupational carcinogenic exposure, the European Commission has updated OELs for carcinogens and initiated revisions to the methodology for setting OELs. A health-based approach to OELs, including cancer risk assessments based on predefined levels, has been adopted by EU member states such as Germany, the Netherlands, and France. In Germany, the German Committee on Hazardous Substances, which is called AGS, they review OEL proposals from other organizations, primarily the MAKS Commission. AGS has developed a risk-based framework for assessing carcinogenic exposure, which categorizes risk as high, medium, or low. The acceptable risk level is defined as 4 per 10,000 workers developing cancer over a lifetime. In Netherlands, OELs are recommended by the Dutch Health Council. All OELs are health-based except for carcinogenic and mutagenic substances, for which no safe health-based OELs can be established. There are 2 risk levels used. First one is prohibitive, meaning cancer risk capped at 10 to the negative 4th per year. There's target risk level, which is cancer risk limited to 10 to the negative 6th per year. In France, OELs are set for both threshold and non-threshold substances. Threshold substances have a safe exposure level below which no adverse effects are expected, while non-threshold substances, such as carcinogens, pose a risk at any level of exposure. For non-threshold carcinogens, OELs correspond to excess cancer risks of 10 to the negative 4 to 10 to the negative 6. When a quantitative assessment isn't possible, OELs are based on technical feasibility and referred to as pragmatic OELs. The critical need to incorporate cancer risk into PELs is exemplified by the case study on trichloroethylene, TCE. The original PEL for TCE of 25 ppm was set prior to its recognition as a carcinogen based on its impacts on the central nervous system, kidneys, liver, immune and reproductive systems, and the developing fetus. This limit, established in 1988, did not anticipate TCE's carcinogenic potential. Later recognized by several authoritative bodies, these classifications, based on robust evidence of TCE carcinogenicity, highlighted the inadequacy of the existing PEL to protect workers. In response to these findings, OSHA adopted a stringent cancer risk threshold of 1 in 1,000 for calculating PELs in 2007 based on a recommendation from the California Department of Public Health and the Office of Environmental Health Hazard Assessment, which is called OEHA. OSHA found that exposure over a 40-year working lifetime to TCE at the original PEL of 25 ppm would be expected to produce 106 additional cases of cancer per 1,000 workers, more than 100 times over OSHA's 1 in 1,000 cancer risk threshold. The application of this cancer risk threshold with the TCE inhalation unit risk level, called URL, of 2.0 times 10 to the negative third resulted in dramatic reduction in the PEL of TCE from 25 ppm to 0.7 ppm, which at the time met OSHA's 1 in 1,000 risk threshold. Further evaluations continued to refine these limits. In 2010, the Health Effects Advisory Committee recommended lowering the PEL further to 0.4 ppm based on TCE being classified as a probable human carcinogen. And in 2011, the USA EPA review doubled the TCE inhalation URL from 2.0 to 4.0 times 10 to the negative third, indicating TCE was twice as potent carcinogen as previously thought. And this led to the final TCE PEL of 0.2 ppm. This research is centered on three main objectives. Firstly, to calculate new PELs for 116 carcinogenic chemicals identified in OSHA's AC-1 list using URL and a cancer risk threshold of 1 in 1,000. Secondly, to assess the cancer risk associated with each current PEL, quantifying the potential health risks posed to workers. Finally, to compare PELs in the US with OELs from Germany, the Netherlands, and France, which are distinguished for their health-based approach and explicit consideration of cancer risk. This comparison aims to highlight the differences in regulatory approaches to carcinogen OELs and explore the potential for more health-centric standards. We use the AC-1 list from OSHA section 5155 to identify common chemical contaminants in the workplace and their PELs. The AC-1 list contains 632 unique chemical substances, and to identify which chemicals under AC-1 list are carcinogenic, we identify which AC-1 chemicals were categorized as causing cancer or causing both cancer and developmental toxicity on the Proposition 65 list. Of the 564 chemicals on the Prop 65 list identified as carcinogens, the 116 chemicals on the AC-1 list were identified as carcinogens on the Prop 65 list. To determine the cancer-based PELs for the 116 carcinogenic chemicals, we adopted the methodology used by OEHA and OSHA to calculate PEL of TCE. The equation is shown here. The cancer risk threshold 0.001 indicates that one additional case of cancer is expected among 1,000 workers exposed to the chemical at its PEL over their 40 years of working lifetimes. URL represents the lifetime cancer risk from inhalation exposure to a unit concentration of a carcinogen, and it varies per each chemical. And adjustment factors account for differences in exposure durations. When attempting to calculate 116 chemicals, not all chemicals had URL values. As of April 2023, OEHA had URL data for only 42 out of the 116 chemicals. Consequently, we were unable to calculate cancer-based PELs for the 74 chemicals on the AC-1 list. Our second objective was to assess the cancer risk posed by the current PEL associated with each chemical on the AC-1 list. To do so, we used the method developed by OEHA and OSHA. The equation is shown here, and the existing PELs are the ones that currently on the AC-1 list that does not consider carcinogenic risks. It is multiplied by the URLs and adjustment factors. When calculating the excess lifetime cancer risk, because we needed both URLs and existing PEL values, we only had 42 chemicals to begin the calculation, but we had to exclude 17 chemicals because the 17 chemicals were missing existing PEL values. So we could only calculate the excess lifetime cancer risk for 25 chemicals at the end. Here is the complete flowchart, starting with cross-referencing the AC-1 and Proposition 65 lists. We identified 116 workplace carcinogens. However, when calculating the new PELs, only 42 chemicals had published URL available for use, so we had to exclude 74 chemicals. Additionally, when calculating excess lifetime cancer risk, which requires both URLs and existing PEL values, we were only able to calculate risks for 25 chemicals. To assess the health impacts of proposed PEL revisions, we determined the differences between the existing PELs and the cancer-based PELs. We also examined the cancer risks tied to the existing PELs. This evaluation involved calculating the excess lifetime cancer risk for the subset of 25 chemicals where both existing PELs and URLs values were available. Furthermore, we quantified the excess lifetime cancer risk cases that could be prevented by adopting the cancer-based PELs by comparing the cancer risk calculated using the existing PELs against those derived from the cancer-based PELs. To deepen our analysis of the need to update current PELs, our study has expanded to include a comparison with the OELs from Germany, the Netherlands, and France. By integrating the OEL values from these three countries, we aim to assess the variance between cancer-based PELs and existing international OELs. We calculated the differences between the cancer-based PELs and the existing OELs for Germany, the Netherlands, and France. This analysis helped us to obtain a holistic view of the differences in regulatory limits across these countries and to assess how the gaps in OELs, which consider cancer risk, compare to the OSHA PELs that may not. We then assessed the excess lifetime cancer risk associated with the OELs from the three countries using the same methodology introduced in equation 2, employed for evaluating the cancer risk of OSHA existing PELs. This comparison is essential for understanding the impact of adopting international standards on cancer risk levels in comparison to those under OSHA regulations. The first table, it shows how the existing PELs OELs for 42 chemicals across OSHA, Germany, the Netherlands, and France. When comparing existing PELs, it is notable that OSHA's existing PELs for 6 chemicals were higher than those in Germany, the Netherlands, and France. And OSHA elect PELs for 17 out of 42 chemicals examined. Also, Germany and the Netherlands each elect OELs for 9 chemicals and France for 10. And OSHA had the largest number of missing PELs in this comparison. Here is the second table showing the comparison between cancer-based OSHA PELs and the differences between existing PELs or OELs and the cancer-based PELs for OSHA, Germany, the Netherlands, and France. Simply saying, the column in the green box represents the cancer-based PELs, which are the new PELs. The other 4 columns in red box shows the values subtracted from the cancer-based PELs to compare with their existing PELs. Looking at the OSHA cancer-based PELs and OSHA existing PELs, 92% of OSHA PELs were higher than cancer-based PELs, with 1-dichloroethane showing the largest difference, which is 396.82 milligram per meter cube. 2 chemicals, 4-methylene and hexachlorobenzene, had existing PELs slightly lower than cancer-based PELs, meaning their current PELs are more protective than the new PELs. It is the same table from the previous slide, but now when comparing between OSHA cancer-based PELs and Germany existing OELs, it shows that in Germany, 94% of OELs were higher than cancer-based PELs, with 1-dichloroethane showing the largest gap, which is 206.82 milligram per meter cube. Germany had tighter controls for 2-ethylhexyl and formaldehyde compared to cancer-based PELs. And lastly, comparing between OSHA cancer-based PELs and the Netherlands and France's existing OELs, it shows that the Netherlands and France had 82% and 94% of the OELs higher than cancer-based PELs, respectively. And overall, comparing the OSHA cancer-based PELs and existing PELs and OELs, 1-dichloroethane, tetrachloroethylene, dichloromethane, and ethylbenzene showed substantial differences across all regions. 3 chemicals, which are 3-dichlorobenzene, 4-dimethylaminoazobenzene, and N-nitrosyl-dimethylamine, had no established PELs or OELs in any regions. Table in this slide shows the excess lifetime cancer risk values for 25 carcinogenic workplace chemicals based on existing PELs and OELs in OSHA, Germany, the Netherlands, and France. Some significant findings from the existing OSHA PELs cancer risk value is that 2-chloroethyl showed an excess cancer risk of 4,180 cases per 1,000 workers, far exceeding OSHA cancer risk threshold. Naphthalene's cancer risk was much lower in OSHA, 3 cases per 1,000, compared to other regions. OSHA's cancer risk for 2-chloroaniline was significantly lower than other jurisdictions. The same table, but looking at the cancer risk value of Germany's existing OELs, shows that Germany had the most chemicals with lower excess lifetime cancer risk values compared to OSHA. Notably, 4-methylene, which is also called 2-chloroaniline, had a cancer risk 274 times greater than OSHA value. Germany's cancer risk for naphthalene was much higher than OSHA, but lower than the Netherlands and France. Now looking at the Netherlands cancer risk value of their existing OELs, it shows that the Netherlands has the largest excess cancer risk for ethylene oxide, which is 743 cases per 1,000. And 11 chemicals showed lower case cancer risk compared to OSHA, while 7 chemicals, including 1-dichloroethane and ethylene oxide, had higher risk values. Naphthalen's risk value was 111 times higher than OSHA. And lastly, for France's cancer risk value of their OELs shows that France exhibited 11 chemicals with higher cancer risk values compared to OSHA. Naphthalene had a similar elevated cancer risk to the Netherlands, 111 times greater than OSHA. Only 3 chemicals had lower cancer risks than OSHA. And overall, the cancer risk values shows that 2-chloroethyl had the highest excess cancer risk, 4,180 cases per 1,000 workers across all regions, indicating a significant occupational hazard. And 1-dichloroethane, tetrachloroethylene, dichloromethane, and ethylbenzene showed substantial discrepancies in cancer risk across jurisdictions. Now we have a table that compares the excess lifetime cancer risk based on OSHA's existing PELs and the new cancer-based PELs, along with the calculated preventable cancer risk values. This table shows how many people can potentially be saved by adopting cancer-based PELs. The pinkish purple columns represent the existing PELs and their associated cancer risk values, while the blue columns represent the cancer-based PELs and their cancer risk values. The cancer risk values for the cancer-based PELs are all set to 1 because they use a cancer risk threshold of 1 in 1,000. The preventable cancer risk is calculated by subtracting the cancer risk value of cancer-based PELs, which is 1, from the cancer risk value of the existing PELs. Looking at the preventable cancer risk values, it is notable that 2-chloroethyl potential reduction of 4,179 cancer cases and acrylonitrile had potential prevention of 255 cancer cases. For 4-methylene and hexachlorobenzene, current PELs are more protective than cancer-based PELs. Some key findings of this study was that 92% of OSHA PELs and most OELs from Germany, Netherlands, and France are higher than newly calculated cancer-based PELs. And there are 3 notable chemicals that showed some significant impacts, which are dichloroethane, hydrazine, and 2-chloroethyl. The dichloroethane's current PEL in the US, the Netherlands, and France are 125 times higher than cancer-based PELs. The hydrazine's current PEL and OELs for all regions are 13 times higher than cancer-based PELs. And the 2-chloroethyl, which had current OSHA PEL, predicts 4,180 excess cancer cases per 1,000 workers, indicating workers are over 4 times more likely to develop cancer. In a global context, the research showed that for Germany, lower cancer risk values for 11 chemicals compared to OSHA, reflecting stricter safety measures. In the Netherlands, they exhibited significantly higher cancer risks for chemicals like naphthalene, which had 334 cases per 1,000, and ethylene oxide, which had 743 cases per 1,000 compared to OSHA. France had higher cancer risks for 11 chemicals compared to OSHA, with risk levels similar to the Netherlands for certain chemicals like naphthalene. Overall, the safest PELs in this study turns out to be Germany, as they consistently showed the lowest cancer risk values across most chemicals, including that its OELs are relatively safer than other jurisdictions that were compared in this study. This slide summarizes the 2 chemicals that showed the highest cancer risk value from its existing PELs, and they are 2-chloroethyl and acrylonitrile. As described here, they should be considered as urgent chemicals to be updated because 2-proethyl has current PEL of 30 milligram per meter cube, could result in 4,180 cancer cases per 1,000 workers over a lifetime exposure, and a proposed cancer-based PEL would reduce this number to just one cancer case per 1,000 workers, preventing 4,179 cancer cases. The current high risk suggests workers are 4.18 times more likely to develop cancer under existing PELs, underscoring the urgency for revision. Acrylonitrile has current PEL that could result in 256 cancer cases per 1,000 workers. By adopting a cancer-based PEL, 255 cancer cases could be prevented, bringing the risk down to 1 case per 1,000 workers. This demonstrates the effectiveness of cancer-based PELs in drastically reducing health risks for workers. Here we have important figures representing the number of people we could potentially save from exposure to carcinogenic chemicals. The top 6 chemicals with the highest potential to save lives are 2-chloroethyl, acrylonitrile, tetrachloroethylene, vinyl trichloride, and dichlorobenzene and dichloroethane. The first 2 chemicals were already introduced in the previous slide, but for tetrachloroethylene, reducing the PEL to cancer-based level would lower this to just 1 cancer case per 1,000 workers, preventing 202 cases. Vinyl trichloride adopting cancer-based PELs could prevent 140 cases per 1,000 workers. For dichlorobenzene, implementing the proposed PEL could prevent 129 cases per 1,000 workers. Lastly, the dichloroethane, a revised PEL could prevent 125 cancer cases. Overall, adopting cancer-based PELs across these chemicals would result in the prevention of thousands of cancer cases, significantly improving worker safety. This highlights the critical need for regulatory updates to reduce cancer risks in occupational settings. The stark difference between current and cancer-based PELs emphasizes the need for immediate action. Cancer-based PELs offer a proven pathway to minimize health risks and protect workers from occupational cancers. Some limitations in this study are first, incomplete data for all carcinogens. Cancer-based PELs and cancer risk values couldn't be calculated for all 160 carcinogenic chemicals because of missing URLs for 74 chemicals, undefined PELs for 17 chemicals on the AC-1 list. Second, gaps in international comparisons. There were 8 chemicals have established OELs in Germany, the Netherlands, and France, but lack corresponding PELs under OSHA. Third, these data gaps restrict the scope of the analysis, limiting the accuracy and comprehensiveness of the findings. Workers may be exposed to unsafe levels of carcinogens due to the absence of well-defined PELs. Fourth, additional data collection and research are essential to fill these gaps. This would enable better risk assessment and support the development of more protective regulatory policies for occupational carcinogen exposure. Some recommendations from this research is that conduct cancer risk assessment for chemicals making URLs to calculate PELs, establish PELs for carcinogens missing from the AC-1 list to improve worker protection. And OSHA should adopt OSHA's method for setting cancer-based PELs to align with current science. Revising PELs based on cancer risk will improve worker safety. And lastly, unify national and international OELs to align cancer risk thresholds, standardized risk assessments to simplify compliance and ensure worker protection. I've summarized the study here. The study initiated with the fact that occupational carcinogen exposure is a major global health risk, and current OELs, including OSHAs, do not sufficiently protect workers. And the study proposes new cancer-based PELs for 116 chemicals using a 1 in 1,000 cancer risk threshold to improve worker protection. PELs were recalculated using URLs and cancer risk thresholds, comparing them with OELs from Germany, the Netherlands, and France. 92% of OSHA PELs are higher than the new cancer-based PELs, with chemicals like dichoethane reduced from 100 ppm to 0.06 ppm. International oils are generally stricter than OSHA, but still higher than the newly proposed cancer-based PELs. I want to acknowledge that Dr. Mike Wilson at OSHA providing the opportunity to work on this project. His guidance through the research framework and data gathering process has been invaluable. Also, Dr. Elizabeth Nolt at UC Berkeley, she provided insightful critiques and holistic review of the research, and it greatly helped me. And lastly, Dr. Leila Huang at UC Berkeley, providing me with a consistent mentorship and invaluable feedback throughout my thesis writing journey, and I truly appreciate her help. Thank you for listening, and I will happy to answer any questions in my best.
Thank you so much for sharing your research with us and for doing this work. We do have some time for questions. So if you have any questions for our presenter today, please go ahead and enter it into the Q&A box. It's a little easier for me to keep track of the questions coming in when they're in the Q&A versus the chat. So first question, and we've gotten this question in a couple different forms, so I'm going to summarize it. Can you just share a little bit around why the threshold is 1 in 1,000 when it comes to the cancer risk threshold?
Actually, because I directly followed the OEHAS method on calculating the new pills, and I didn't really look deep into why they choose 1 in 1,000 cancer risk threshold. But yeah, I think I can go deep into it because it's way stricter than what other countries or the current jurisdictions use.
Thank you so much.
Of
Um,
course.
yeah, and that actually leads into another question that we've had come in. And this is, I know your presentation focused on California, and Cal OSHA in comparison to some other countries. There were some folks who were also wondering in terms of federally, in the US. Did you happen to look at where our California PELs versus federal PELs might have been in alignment, or were you more exclusively focused on California?
The research is, yeah, it is focused on California pills, but from my experience working at private industry and also in academia, I often find that um, the federal OSHA pills are way higher than all the NIOSH pills, ACGIH, TLVs, and Cal OSHA pills. So if we used OSHA pills in this study, then we would have had more like higher cancer risk values. And because like oftentimes OSHA pills are similar to NIOSH pills and TLVs, I think that kind of helped more on like how much stricter we should be for the future. Because I feel like everyone kind of knows like OSHA pills um are not protecting the workers in the best way.
Thank you for sharing. Um, that actually leads to another question that has come in. Um, oh, and I lost it. Just one moment. Where
You're
did
fine.
Thank you. Um, do we know how, or as these exposures to numerous chemicals have existed for possibly decades, is there any exposure data demonstrating exposures and morbidity due to these exposures?
That's a really good question. So when we were designing this research, I actually wanted to include that part on like looking at how much of these chemical being produced in the states from certain time frame, but it was really hard to match that with how much exposure to the workers because even though this chemical is produced this amount, that doesn't mean it's being exposed to the same amount. So I was like more looking, I thought like for the purpose of research, we wanted to um, put this new PELs out to the world first. So that part got pushed out a little bit. But for sure, I'm planning to do that research in the future, like near future. But thank you for asking the question. That's really important factor also.
Thank you so much. Do you know, do the ACGIH TLVs have a cancer risk threshold?
Um, Based on what I researched during my MPH degree, which is like when I was doing like starting this research like 2 years ago, 1 year ago, I didn't find any research that's saying ACGIH TLVs, they when they're established in the PELs, they include carcinogenicity as their health endpoint. But mostly they include all the inhalation exposures, reproductive exposure, but I I mean the respiratory exposure, but for my knowledge at the moment, I don't think ACGH they include carcinogenicity as their health endpoint.
Thank you. And this actually connects to another question. OELs are based on airborne exposure. What about dermal exposure? Are there any OELs for that or anything that you looked at?
That's that's a really great question because my next research in my PhD program is going to be thermal exposure to disinfectants among pest control workers. So um, I didn't look at the thermal exposure when I was doing this research, but as I come to Minnesota and like starting like reading more papers to kind of scoping out my research like dissertation, I found that many papers saying thermal exposure is really hard to conduct and hard to interpret and how hard to sample because um, the amount of those being exposed to person, it does not mean like all of those doses will be penetrated in the skin. So that's really that and that got me interested in like then how we going to protect those workers who are often get the skin exposure, which is thermal exposure. So that's a great question. I hope to answer it in next 5 years. So watch for my dissertation.
Excellent. Thank you. And another question, in kind of thinking about the different chemicals that you looked at, are you able to share anything around what industries or processes that some of these different cancer-causing chemicals are used, or what applications they might have, and kind of why, if we, why are we still using them?
For sure, there like among the list that I shared, there are chemicals that are not being used in the industry anymore because it is known as um really dangerous to humans. But I didn't point that out because the purpose of research was just to show the new pills. But as I said in the previous question, when I try to look at the amount of chemicals being produced, I kind of wanted to see what are the like industry categorizes of each chemical, like which industry uses the most. And from my memory, it was metal fluid or plastic industry. But I cannot be sure about my answer. I can go back to the research documents. But yeah, from what I remember, it was metalworking industry.
Thank you so much.
Of
Are you able
course.
to speak to some of the challenges involved in updating PELs, both in the United States and in California?
I think there is a big challenge in terms of updating the federal OSHA PELs, definitely because I know like we already have NIOSH PELs, ACGH TLBs, Cal OSHA PELs, which are way more stringent than federal OSHA PELs, but federal OSHA hasn't updated PELs yet. So that's really challenging. But from like with Dr. Mike, our purpose of this research is that, but people still should know that these chemicals are dangerous and it could potentially cause cancer with the current pills. So there's a big challenge there. But because California OSHA pills, they're more open to update their pills. So that's why that's why my um, advisor, which is who's Dr. Mike, he really got into this research and pulled me in. So yeah, I think everyone knows there's a big challenge with federal OSHA pills. And I know a lot of in a lot of private industry, a lot of like professional IHs, they always use the most strict OELs, PELs available, which is awesome. But yeah, I think yeah, if that yeah.
Thank you. Another question, if we were to implement lower cancer-based PELs, would there be any technical feasibility studies to accompany them? For example, do we have the sampling and analytical methods to support a lower PEL?
That's a great question. That's what this study makes it more difficult because 1 in 1,000 cancer risk threshold is such a low threshold compared to all the other countries or in the US we used. Um, so I think we need to find a way that like I think we need to find an agreement in between to be more realistic. And in terms of like those like sampling methods for conducting the samples, that's another whole story. Like that could be another whole research on what are the best way to really implement these pills uh, realistically. But yeah, I think I always thought like even writing this paper, I thought like this is just gonna be so hard for the industry to implement because it's just a so low ppm. It's just and the workers they also don't like to wear a lot of PPEs because it's uncomfortable. But yeah, I'm sorry if that answers the question. I just
Thank you, thank you, thank you.
of course.
Another question, and this is kind of going back to that 1 in 1,000 threshold. What do you think about considering the 1 in 10,000 recommendation for cancer risk by NIOSH?
Um, I think that 1 in 10,000 is relatively lower than the Germany, the Netherlands, and France has. So I think it is definitely a different way to approach when developing new pills or revising the pills. So, but I would like to, but I would be interested in looking at like um, if we could find a different agreement between 1 in 1,000 and 1 in 10,000, or it could be different for per types of chemicals, like different carcinogenicity. Um, yeah.
Thank you. Another question, what do you think about the precautionary principle? You know, the idea of proving that things are safe versus trying to retroactively address the harms. What are your thoughts on that, and any chances of something along that lines being passed and regulatorily in California?
Um, could you repeat that question again?
Yeah, someone was just wondering about your thoughts on the precautionary principle, essentially putting the onus on others to, or those manufacturers to confirm that the chemicals are safe before allowing them to be distributed.
Used. Oh. Because the PELs are all depends on amount of being exposed to the workers. So and I think there should be another regulatory or standard when those carcinogenic chemicals being produced and sold to the industry, so that the people in the industry, they could actually know way before they're getting the chemicals, and if there's any alternative chemicals they can use to protect workers and also to ease the process. So yeah, I think yeah, but I think it's gonna be a little hard because um yeah, like like it's just so hard to update the PELs, and it's gonna be another issue with creating new laws, and I think that's gonna annoy a lot of industry. So yeah,
Thank you. Another
of course.
question. Was there anything specific or a specific compound or threshold that surprised you? And did you notice any patterns in terms of kind of comparing these chemicals across different countries? Anything that shocked you?
I mean, of course, the 4,180 excess cancer risk for the 2 um chloroethyl was just mind blowing, because I was not sure if I calculated right at the time. So with Dr. Mike, we went over multiple times, so like to make sure this is the correct value we have. And also it was hard to like interpret what that means when we are saying like 4,180 people could get cancer in 1,000 people. It doesn't make sense. So we try to like best assume what that means, and we finalize that this could mean like there's 4 times higher risk of getting cancer um, when using these chemicals. But yeah, that was really um, mind-blowing result from the research. And also it was interesting to see there are a few chemicals um, that actually like the current pills were actually safer than the new pills. So I think those chemicals were pretty interesting, and I realized those ones are like formaldehyde or those, like long time known chemicals for danger. So I thought that was pretty interesting.
Thank you so much for sharing and for pointing that out. That actually answered another one of the questions that we had in the chat. Is
Awesome.
how can there be 4,180 predicted
Yeah,
cancer cases for a
I know,
thousand
that's
workers?
crazy. Mhm.
Another it shocked an attendee as well. So yes, it's workers are very likely to develop cancer due to that chemical. So thank you so
Mhm.
much for sharing that. Um, Another person followed up regarding the precautionary principle, noting that it doesn't allow any chemicals into the environment that are harmful to all living beings. The
Mm.
European Union has passed it. And just noting that there are 85,000 chemicals in our environment that we don't know if they're safe. So we can only demand that they be removed only when folks are exposed. Do we
Mm.
start to see some of these impacts? So thank you for sharing that information in the chat for me,
Of
Michelle.
course. Thank
Uh,
you for saying.
Another question. I'd like to zoom out just a little bit and also just ask, what was your favorite part about doing this research? And I know you mentioned you're continuing on to get a PhD. So what were some of your favorite things about doing this?
Um, I think I just like to see like um I was really interested in chemical exposure from the beginning, and that was one of the reasons why I decided to study in the States. And then I've been looking for opportunities to actually study on this and become more like knowledgeable in this field. But one thing that, like one part that I really liked about this research is actually when I was cross-referencing the Prop 65 list and AC-1 list, hoping that there's not much chemicals that are um, cross-referenced together. but there were 116 chemicals. So Dr. Mike and I got really shocked. And that amount of sample size motivated me to do this research more meaningfully, because there might be workers who are being exposed to these chemicals with the PELs, and they should know that uh, they're being exposed, and we should at least publish this article so people can know. And after doing that, because this research was like 1 year thing, I really wanted to expand more in terms of like how I can become like a person that could design the research and actually help the people who needs help. So that's why I decided to pursue PhD again in occupational hygiene program. Um, and it's been really interesting and fun to be in a new city and with all the other people around the world. And yeah, and then I'm really looking forward to learn more about the thermal exposure and what would be the best way to conduct the samples and how we can prevent it eventually.
Thank you so much for sharing. Another follow-up question, how do we compare, the calculated estimate of cancer risks in comparison to actual cancer occurrence rates? Can you share a little bit about how, I guess, the methodology of deciding, oh, this is the cancer occurrence rate for this particular chemical? What kind of assessment goes behind establishing what that possibility of cancer is, if we don't necessarily have the actual cancer occurrence rate to compare against?
So I think this research was more simplified than comparing between the actual cancer rate. Um, because we are like doing the mass calculation. So this equation is getting the new PELs, which is cancer-based PELs. We have this cancer risk threshold and divide that by URL, which is the lifetime cancer risk from inhalation of carcinogen at a given concentration. So this URL is the main value we compared, and then we try to get the cancer-based PELs for. So I think that's a great point that we should actually um, use the actual cancer risk rate than URLs, or maybe we should look at like which ones um, better when actually establishing new PELs. That's a great question.
And do these URLs come from rat inhalation studies, or do they come from other
Yeah,
sources?
they're from OEHA. They have the set of chemicals, and then they also have this unit risk levels next to it. And it is inhalation based. It does not include dermal or other route of exposure.
Wow. Thank you again so much for your work, and all of your
Of
research
course.
and sharing it, and answering all of these different questions that came in. Thank you. We have
Of
about a
course.
minute left. Do you have any closing thoughts or anything else you'd like to share with the audience to wrap up today's session?
Yeah, thank you so much for everyone joined the webinar. I did not expect this much people will be listening my research, my small tiny research. But all the questions really help me what other research questions I should have when thinking about establishing new PELs. So, and I hope to address that with the next 5 years. And yeah, it was really pleasure to be here and then present my work. Thank you so much.
Amazing. Well, thank you so much for your research and great job. Thank you to everyone who joined us for today's session. Yes, the session was recorded, so we'll have the recording available in the next 5 business days. So be sure to check us out back online at COEH at berkeley.edu/aboutce. Thank you again for your wonderful questions and participation in today's webinar. And thank you, Jisoo, for your presentation and your research. I hope
Yeah,
you
of
have a
course.
wonderful day.
Thank you.
Thanks, everyone.